Hello, my name's Laura Coates, and I'm an academic rheumatologist based at the University of Oxford in the UK. And I'm going to talk you through a little bit of how we consider treatment selection in psoriatic arthritis, thinking about patient characteristics, disease characteristics, and comorbidities when we select therapy. I think we're increasingly lucky in psoriatic arthritis that we have an embarrassment of riches, really, in terms of the treatments that we have. And that's lovely. Things have changed a lot in the last couple of decades, and it's great to have a good selection of drugs available to us. But it brings its own problems. When we only had a few drugs, it was very simple how to choose them because you didn't have many options. But now we have more and more drugs available to us. It gets much more complicated to choose between the drugs and select the right drug for the right patient. So in terms of the therapies that we have available, I would consider here both conventional DMARDs like methotrexate, leflunomide, sulfasalazine, biologic DMARDs, TNF inhibitors, IL-12/23, IL-23, IL-17, and then some of the oral targeted synthetic DMARDs like JAK inhibitors and apremilast, the PDE4 inhibitor. So when we're thinking about selecting therapy, I think probably the first thing to think about is the domains of disease that are involved in that particular patient in front of you. So we've got a few head-to-head studies in rheumatology, some more in dermatology, and it's become clear really that I think the key domains that help us to differentiate between different drugs are axial disease, where less drugs are effective, and skin psoriasis, where we see a differential level of efficacy. So, for example, in axial disease, as a first choice, we're going to avoid conventional DMARDs because they don't have evidence that they work. So you would go straight from NSAIDs up to biologics if required. Whereas in peripheral joint disease, we're typically going to try a conventional drug first. In axial disease, we've only got 3 different modes of action that have proven efficacy in axial disease, and that's TNF inhibitors, IL-17 inhibitors, and JAK inhibitors. But if somebody has peripheral joint disease, we have a much wider selection of drugs available to us. And then that second domain, I think, where we have differential efficacy is in skin psoriasis. So there's quite a large number of head-to-head studies now in the dermatology literature. And we've got a few studies in rheumatology that have gone head-to-head, typically against adalimumab. And most of those head-to-head studies have shown similar outcomes for peripheral joints, but better outcomes in terms of skin disease for the newer biologic therapies. So drugs like IL-17 and IL-23 inhibitors being superior to TNF in terms of efficacy. And then beyond those domains of disease, I think the other things are going to be comorbidities. So the kind of obvious related conditions that we consider in psoriatic arthritis, things like inflammatory bowel disease and uveitis, obviously is going to heavily influence our choice. So with uveitis, we've got evidence of efficacy for TNF inhibitors and indeed a license for adalimumab for some forms of uveitis. For IBD, we've got evidence of efficacy for TNF inhibitors, for ustekinumab, and we've now got developing data for IL-23 and for JAK inhibitors, but we've got a caution around using IL-17 inhibitors where IBD can be flared by those drugs. So any presence of those related conditions is very directly going to influence on our treatment choice. And that's where ideally we're working with the other specialists. So we're talking to the gastroenterologists about what treatments they have available, what they've tried so far, and trying to pick a drug that will treat both things if the patient is struggling with symptoms from both. And then the wider comorbidities in psoriatic arthritis are obviously a big issue, but I think we have less data on how we select therapy based on those. So comorbidities like depression, cardiovascular risk, the metabolic syndrome. I think we have an idea that overall controlling disease and controlling inflammation is good, but we haven't really got anything that helps to differentiate between the drugs. I guess here I would bring in a caution about the JAK inhibitors. We need more research in psoriatic arthritis patients specifically, but obviously there is a caution around using these drugs in older patients with cardiovascular risk factors And so that's probably the biggest point where comorbidities come into a selection of therapies. And obviously the future, hopefully, is that we will have a more efficient and precision way of doing this with precision medicine. So there's a lot of research ongoing, looking at potential tissue biomarkers from biopsies, as well as peripheral blood biomarkers. And hopefully in the future, we'll be able to develop a useful test that can help you select drugs for your individual patients in clinic. But for the moment, I think this comes back to the art of being a medic and the art of being a rheumatologist and thinking about different characteristics of that patient in front of you. So domains, particularly their relative efficacy in skin and axial disease to help you choose between drugs, the presence of any related conditions like IBD and uveitis, and then any relevant thoughts for different comorbidities in terms of cardiovascular risk or other comorbidities that may be impacted by these drugs. Thank you very much for listening.